Hello, welcome to the February Clinical Immunology Society webinar. And so we are excited that you all have joined us tonight. This is a monthly webinar put on by the Early Career Immunologist Committee. And we're excited that you're here. My name is Erica Schmidt. I'm a pediatric rheumatologist and immunologist at Washington University in St. Louis, and I will be your moderator for the evening. We like these discussions to be interactive, and we have built in several points for discussion. If you see in your chat box, make sure you set your chat to everyone and not just hosts and panelists so that we can all see your comments and questions. Tonight, we have a great case from Washington University in St. Louis by Dr. Armin Sanosen. He's a fellow in allergy and immunology here. And we also have a wonderful senior mentor, Dr. Niraj Patel. He's an associate professor from Duke University in the pediatric allergy and immunology department. And so with that, I will turn it over to Dr. Sanosen, and we will get started with our case.
Hi, everyone. Thank you very much, Dr. Schmidt, for your kind introduction. And thank you, Dr. Patel, for agreeing mentoring me today. I'm very glad having this opportunity to share this case here, discuss and have your comments and suggestions. Before I start, let me verify if everyone sees this as a presentation, so then we can move forward.
Looks great.
Fantastic. Thank you. Overall, my objectives today are to discuss the early signs of hyper IgE syndrome caused by dominant negative STAT3 variants, recognize rare immune and non-immune complications, and talk about strategies of management. I have no conflicts of interest to disclose. And let's jump straight to the case. And we first saw this patient as an inpatient consult. He was a 7-week-old male admitted with failure to thrive due to watery stools and vomiting with formula. He also had oral thrush and diaper rash, described as shallow ulcerations. He was born at full term via C-section due to maternal hypertension and fetal breech position. His initial weight, head circumference, and length were appropriate for gestational age. While in the nursery, he required oxygen support and was evaluated for neonatal sepsis with negative results. His examination in the nursery also described a generalized pustular rash. He was then discharged home with the family, and at about 1 month of age, he developed loose stools, thrush, and diaper rash. He was initially treated with nystatin and topical clotrimazole for his diaper rash, and then was switched to hydrolyzed formula. Due to persistent thrush, fluconazole was started a week later. When he was admitted in our hospital, he was already about for 2 weeks on fluconazole. Here is the diaper rash and what was described as shallow ulceration. And MSSA and MRSA culture from his skin were negative, and it was probably a chemical irritation from his persistent diarrhea. And CBC showed eosinophilia about 1,400 cells per microliter. His newborn screening for SCID was negative. And here my question to you is, would this be concerned for immunodeficiency, and what be your first immune workup for this patient?
Okay, we will pause here for our first point of discussion. So feel free to type into the chat box any thoughts or concerns on this. Would this be concerning for immune deficiency for anybody? And what would you recommend as your next workup? We'll give people a second to reply. Don't be shy.
And I'm hoping people will point out maybe some things in this case that might be a little bit different or unusual from newborn babies or infants that you've seen for evaluation.
Okay, we have one comment. If we still think immune deficiency, we need to be careful. So a word of caution. So that's good.
Oh, agree.
With ALC of 3.1, rash and eosinophilia, pointed
Yeah.
out this could be concerning for food allergy. Perhaps a primary atopic disorder has red flags. Another person pointed out the high AEC, concern for possible Omen syndrome, and would rule that out. Yeah, so kind of the thread here is people are concerned about the high eosinophil count.
I agree. I agree. And this is what we thought. And we did initial immune workup with lymphocyte phenotyping. We were also concerned about possible Omen, although the rash was not typical for Omen. And his lymphocyte phenotyping were unremarkable, and TREX from whole blood was within normal limits. CD4 immunophenotyping showed adequate number of naive CD4 T cells and some subpopulation of the CD4 naive T cells carrying CD31, what is known as recent thymic emigrants. Immunoglobulin profile also showed normal levels, including IgE. His chronic viral markers for EBV, CMV, PCR, and also stool cultures were negative. But we have low threshold given his presentations, and we sent the immune genetic workup for this patient. And here is the PID panel and the results. And as you can see, the results show many variants in immune genes, most of which are of uncertain significance, and 2 are reported as pathogenic. I also marked here the pattern of inheritance of the diseases associated with pathogenic form of the given genes. And we can just rule out all that are autosomal recessive listed here because all of our genes reported are in heterozygous form, and only two of them are in autosomal dominant form, which is STAT3 and COL7A1. And here, let me see if I can click it. And the STAT3, as you can see here, was a known pathogenic form for the dominant negative STAT3 hyper IgE syndrome. It replaces arginine with tryptophan at 382 position in STAT3 protein, while for COL7A1, it is reported as variant of uncertain significance, and disease associated with the pathogenic form is epidermolysis bullosa dystrophica, which our patient does not have the symptoms consistent with it. And as far as STAT3 variant is concerned, it was not listed in NOMAD, although there are 5 accessions and all pathogenic in ClinVar, and it is a well-known report here affecting a DNA binding domain of STAT3. None of the parents carried the variants, and this was de novo for the patient. However, this is a well-documented form of STAT3 dominant negative variant causing hyper IgE syndrome. Briefly touching on the pathophysiology of immune effect of STAT3, and STAT3 is a downstream signaling for many cytokines, IL-6, IL-10, IL-11, IL-21, 22, and 23. It primarily affects Th17 cells, but also impacts T follicular helper cells, affinity maturation, and likely induced regulatory T cells.
So I was going to ask a question about the T cell pathway, but I saw a couple of comments in the chat about eosinophilia, and that's a great question, and about an infectious workup. And what Armin presented was a couple of studies, very limited EBV and CMV and PCRs, and then a stool culture that was negative. But I guess I'm just curious from the audience, knowing that this patient has STAT3 now and associated eosinophilia, would people still be worried about an infectious etiology at this point? And if so, what other maybe lab tests would you want to do?
We have one comment, perhaps a parasitic infection workup, staph culture, Yep, still may want to rule out parasites. So those are some of the comments coming in from the audience.
All right. So with that in mind, I'm not going to answer those, but if Armin, you want to keep going.
Yes, thank you. So interestingly, briefly talking about clinical presentations, I will not go in detail, of course, over each possible symptoms, but from these presented here, our patient had only Candida and eosinophilia when he was diagnosed with STAT3 hyper IgE syndrome. I would like to remind you that by the time we diagnosed him, his IgE was normal. And from this review from 2017, the mean age of diagnosis in the United States is about 13 years, and more than half of the cases are due to de novo variants. So we don't know which of these presentations actually presented the first time, but we know from the course of his condition that he had newborn rash, of that pustular rash that was described in nursery. Now, returning to our case, while this patient was admitted, we switched him to elemental formula and his diarrhea resolved and his feeding intolerance resolved as well. And soon after that, the diaper rash significantly improved. His thrush responded to fluconazole after that. It was really hard and challenging to advise the family on starting antibacterial prophylaxis when the child's symptoms improved. However, we agreed on Bactrim and skincare with moisturizers and chlorhexidine wash. So, and we kept eye on the patient, knowing that at this time we just diagnosed him being asymptomatic, and we were continuously following him up. And his next visit was between 6 and 8 months of age. He had this papular rash, eczema managed with topical steroids and moisturizers. Skin cultures returned negative for MRSA and MSSA. We discontinued chlorhexidine. Actually, dermatologist discontinued chlorhexidine wash. His milk-specific IgE was negative, so we started to reintroduce the dairy. And as you can see, this here is flashy rash seen around his armpit. That was something that was characteristic of his rash. At his next visit, between 12 to 15 months of age, his skin care was taken by the pimecrolimus on his face and topical steroids and moisturizers for his eczema. His diaper rash was well managed with Desitin and Vaseline. He already had 2 episodes of otitis media, which both resolved with amoxicillin clavulanic acid. This is not unusual to see otitis media in this age patients. And his next follow-up visit, when he was already 20 months of age, he has already had additional 2 episodes of otitis media, and ear tubes were placed. He continued having facial rash and eczema, and at that visit, we decided to work him up for humoral immune markers. He continued having higher eosinophil count, as you can see, about 1,200. And the first time in the course of his condition, we detected elevation of his IgE. Interestingly, it coincided with specific antibody deficiency to Prevnar 13, and the highest levels, titers were 0.2, and 10 out of 12 had less than 0.1, undetectable levels in a fully vaccinated child. It was unfortunate to see the disease taking its course, but it was easier now to discuss and reinforce the need of restarting the antibacterial prophylaxis with Bactrim, and at the same time, we decided to boost him with Pneumovax. Now,
and there's one question about his immunology workup. Had you looked at Th17 cells at all at this point, or phospho-STAT3?
No, we did. Yeah, that's a good question. We did not look at it because the clinical course took such a typical presentation with a genetic known genetic pathologic variant and his clinical presentation at that time.
I would be curious to just know if there would be any others or any advantage of doing Th17 or phospho-STAT3 in this patient, knowing the genetic diagnosis and the clinical course up until now.
Yeah, it would be interesting to have it. No, we did not do that. We did not have it. So with this, we decided to boost him with Pneumovax. Although there are some reports that Pneumovax in these patients can have severe local reaction. And I would like to know if any from the audience have ever experienced any side effects from Pneumovax in this group of patients.
Actually, I had a patient, Armin. I don't think I told you about this one. This was a older adolescent who ended up getting boosted with Pneumovax by a primary care provider and developed a large local cellulitis. Ended up going back to the provider and getting a short course of Keflex, Sepalex, for which they improved.
Fantastic.
Two quick questions in the
Yes.
chat. Given that the patient had a genetic diagnosis at such a young age, is there anything you can elaborate on with regards to your discussion with the families about having this genetic diagnosis at such a young age, and the counseling, and whether you had considered immunoglobulin replacement therapy even at this time point?
Yeah, that's a great question. And indeed, it is challenging. Now, when we were ordering the genetic testing, that was easier to discuss with the family because the child was sick, and the family wanted also to know if there is any additional lab work that can reveal the reason. And once the reason is found, and we discussed that with the patient's family, and at that time they did not. It was harder to explain because they are reading too, and they could not find any other symptoms consistent, say higher IgE levels. And eventually we were able to start the bacterial prophylaxis because it was kind of I wouldn't say much harmless, but with less adverse effects. So we were able to start. However, upon the course of the follow-up, the family just decided to stop it. But once he was presented with elevated IgE, it was easier to restart it. I agree it is challenging to discuss that, but all these cases with these variants were pathologic. So
I think for this family, it sounded like the genetic diagnosis was a little bit difficult. The family decided not to proceed with Bactrim prophylaxis at some point early on. And for a patient who has maybe what may be considered mild symptoms in the beginning, although this patient was hospitalized, but if you consider the skin rash, ulcerations and the persistent thrush, nothing extremely serious at that point. So they may have felt that that this may be a mild immune deficiency, and maybe that the benefits of prophylaxis may not have outweighed the risks. IVIG for this age, I certainly, for immunoglobulin replacement in patients who have hyper IgE, we know that in some patients there is a recurrent sinopulmonary infections and poor antibody response to pneumococcal polysaccharide. So probably for those patients, IVIG could be considered. I'm not sure unless somebody on the audience knows of a benefit of starting IVIG at 6 to 8 months of age. I don't know that would have a strong benefit in terms of outcome.
Just quick, any other vaccine titers that you had at this point? I don't think we had a B cell profile yet at this point, but did you have Hib or tetanus or anything else?
I think I think we had to boost tetanus as well. I'm not 100% positive with that, but it was also low, not strongly positive, so we went with that too.
I think that's what I recall. All right, we'll let you move on to your.
Great. So we decided to boost him with Pneumovax at 24 months of age. And when they came to our follow-up visit, he was complaining of diarrhea, having about 4 to 6 bowel movements per day. And family again thought it is related to dairy, and they cut dairy with mild to moderate effect. His diaper rash again was managed with clotrimazole and desitin, and he had one episode of visit with vomiting and fevers. Now, we were concerned about GI involvement in this STAT3 dominant negative variant, and we know that it is not uncommon to have the GI manifestations in STAT3 hyper IgE syndrome, but it is mostly upper GI symptoms, and with lower GI involvement, less common. And it is dysphagia, abdominal pain, and reflux, mostly seen in this group of patients. Histologically, it is mostly eosinophilic infiltration in epithelia and subepithelial fibrosis. And in 65% of cases, the histological findings were consistent with EOE. In this article from 2017, there was only one case with self-limited proctitis in a patient with a family history of Crohn's disease. Now, we all know that the IL-10 deficiency, both on ligand and receptor, is associated with very early onset IBD, and STAT3 is a downstream signaling for IL-10, and one should expect to see that with STAT3 too, but it is not that frequent, and likely the reason is that with IL-10, these patients also have lack of Th17, which is an important player in IBD. So anyways, we followed up, we referred this patient to GI, and 10 days before his GI visit, he started to experience, again, worsening of his diarrhea and started to have vomitings, food aversion, temperature instability, hypersomnolence, and the lab that was done in ER showed anemia, basically. When they returned to GI visit, he was tachycardic, had scabbed facial and leg rash, and he had abdominal pain, tenderness, and basically pattern very similar to shock. And here is the rash. You can see the scab rash on his scalp and the typical rash that he had on his legs. Any ideas, any comments here before I move to the labs?
Any comments?
I just want to mention that there was a comment in the chat
Yes.
about IVIG is beneficial at any age, helps to modulate IgE.
Mhm.
And there was another question about considering, or at this point, was there screening for immunologic manifestations of autosomal dominant hyper IgE syndrome? I think you're going to get to that soon. And then there's another question, have you considered using Dupixent on those patients with severe eczema and skin infections? Maybe what we can do is table that question for a little bit later in the discussion.
Yeah. His eczema was not that severe, and it was largely responsive to topical steroids. There are some reports using Dupixent on with GI involvement of these patients, but I'm going to talk a little bit about now. At this point, the patient was ill, sick patient, and was directly admitted from GI to pediatric intensive care unit. And here are his labs. And this pattern very consistent with DIC, shock, and likely sepsis. As you can see, he was severely anemic. And while in the hospital, he required several red blood cell transfusions. He had thrombocytopenia requiring platelet transfusions. And he got plasma transfusions. Interestingly, his inflammatory markers were elevated, but not significantly. You would expect more elevation, higher elevation with this clinical picture. And because he had abdominal pain and abdominal imaging was done, and as you can see here, CT scan revealing appendicitis, thickening of retrocecal appendix and periappendiceal edema. Here you can see Ultrasound of the abdomen revealed hepatomegaly up to 14 centimeters. Chest X-ray showed hazy perihilar and right upper lobe opacities with small lung volumes, favoring to atelectasis, no pleural effusions or pneumothorax. Moving to some additional labs, he had significantly elevated fecal calprotectin. He was also hypoalbuminemic, probably because of a nutritional deficiency or severity of his condition. Here we see the response to his pneumovax, which he did not respond, and elevation of IgE. Again, not as significant as before, but it's still elevated. His microbiological workup, stool ova and parasites were negative. Stool rotavirus antigen and norovirus PCRs were negative. EBV and CMV serology negative. Blood cultures and urine cultures did not reveal any microbial cause of that, and the respiratory viral panel was negative as well. So although he was hypoalbuminemic, he had elevated fecal calprotectin. His ALT, AST were normal, and despite his significant decrease in his coagulation markers, he was febrile, lethargic, having diarrhea. So all the teams decided on the source control, which is appendectomy for this patient. And after appendectomy, patient's condition gradually improved. And however, the likely pathogen for this patient was revealed from the biopsy of the scalp, urine enzyme immunoassay, and the blood was sent for Karius, which is microbial cell-free DNA, and all of those resulted pointing to one pathogen. And any ideas, what was that?
Anybody have a thought? Well, people are coming up with,
Or even a class of
Mhm.
Yeah. Bugs. Is this viral, bacterial, fungal, parasitic? Prion?
Candida was one thought. Anybody else? Staff, couple staff, votes for staff. Mhm. All right, why don't you go ahead, Armin?
Right. So it returned histoplasma for this patient. All these three specimens detected histoplasma capsulatum. The same returned from the appendix histology. As you can see, the GMS staining revealed histoplasma from his inflamed appendix. And then, interestingly, the blood did not grow in the cultures. The fungal cultures did not grow histoplasma. However, it was found in pretty much all of the sources. Both skin and appendix were positive for that too. So based on this, patient further managed with amphotericin, which then was switched to itraconazole. We discontinued his antibacterial treatment and switched to Bactrim prophylaxis. We continued his skin care, nutritional support with vitamins and adequate calorie count. And he was placed on immunoglobulin replacement therapy based on his antibody. Technically, he had a deficient vaccine response, specific antibody deficiency. So he was also discharged on immunoglobulin replacement therapy. Now, for the endemic fungi in hyper IgE syndrome, these are seen in about 7% of the cases. Moreover, they tend to take more severe course and dissemination due to impaired Th17 pathway. And Midwest is an endemic region for histoplasmosis.
Armin, if you want to pause, I'm just curious from the audience if anybody who follows hyper IgE syndrome patients routinely put patients on antifungal prophylaxis before they've had a disseminated infection with fungus. And if they do, which patients, and if they don't, why not? So I see one, yes, we do so in India, okay. Another one says yes, and yes, itraconazole. It looks like the majority of responses here are yes. Another one said posaconazole.
Interesting.
Okay.
In the United States, once we detect the histoplasma as an invasive infection, and we detect it, then we have to put them on lifelong antifungal prophylaxis. But just because of endemic region, I think half of the United States is an endemic region of some fungi. But this is an important question because these patients are at high risk for dissemination, histo affecting more GI tracts, coccidio and crypto having a tendency to affect central nervous system. Involvement of histo and STAT3 hyper IgE syndrome was reported in this article by Odio, Dr. Freeman, and others, where they described 3 cases with disseminated histoplasmosis. And among these 3 cases, 2 are children presented with abdominal pain. And the second case was GI predominant presentation with histoplasma detected in biopsy specimens from the gut. However, no appendicitis associated with histoplasma has been described before in STAT3 hyper IgE syndrome. I was curious to know if histoplasma at all can cause appendicitis or can be associated with appendicitis. I found this old article from 1950 down in Henry Ford Hospital in Detroit, where authors retrospectively looked at removed appendix specimens microscopically and checked the presence of histoplasma in these specimens. And it is very interesting to see that 5% of cases had histoplasma detected not only inflamed, but also in otherwise normal appendixes. It was far more common in patients with mesenteric adenitis. In our case, we also found the histoplasma in the specimens from the appendix. However, none of the cultures grew histoplasma. So, we don't know the cause of dissemination. What do you think? What is the cause of dissemination for this histoplasma? We are curious to have your opinion.
And I don't know if Armin mentioned, but this patient had no evidence of respiratory disease.
Yeah, that's just an atelectasis on chest X-ray and no infiltration, no sign showing.
So, histoplasma lives as a mold in the environment and a yeast when it reaches 37 degrees centigrade. And so, macrophages take up histoplasma to the lymph nodes, and then from there, it can get into the bloodstream. And so, this is a case where, macrophages have taken it obviously to the GI tract, and maybe perhaps bypass the lung, even though the patient probably inhaled the histoplasma.
Yeah.
We have 1 vote for ingestion, then invasion through the gut, and we have another vote for failure of Th17 immunity at the skin and mucosal barrier. So,
yeah, I mean, those are well possible. We cannot trace it back, but we found it in all specimens that we tested, pretty much. The patient was on antifungal prophylaxis. A few months later, this patient was seen in emergency department with complaint of leg pain and refusal to walk. And X-ray detected femoral and tibial fracture, and that happened just because he fell from running. Skeletal survey also detected diffuse osseous demineralization. So this is a new non-immune complication for this patient, presented again early, very young, about 30 months of age. Non-accidental trauma was ruled out then. We know that non-immunological complications are not uncommon for these patients, and the fractures are seen in about 39% of cases, and the median age of the fracture is 11 years of age. And osteopenia and osteoporosis are seen in most of the patients, and bisphosphonates can improve the bone mineral density, but whether this improvement can further decrease the rate of fractures is unknown. So the patient currently is on prophylaxis. Patient is on vitamin D. His leg is casted, and we are thinking about what else can be done for this patient. And hematopoietic stem cell transplant is one of the options. It is not. There are not robust data about the outcomes of hematopoietic stem cell transplantation in STAT3 hyper-IgE syndrome. It is increasingly becoming more common with promising effects on immune manifestations. Other benefits may include stopping antibacterial and antifungal prophylaxis. In the mentioned article from 2021 done in the United Kingdom, authors described 8 cases with dominant negative STAT3 who underwent hematopoietic stem cell transplantation. One of the reported cases carried the same variant as our patient. Here is the variant. He significantly improved in his lung functions. Here is the lung function, skin disease, and even skeletal manifestation of the disease. Interestingly, he developed myocardial infarction at the age of 26, 13 years after the transplantation, and he had ectatic coronary arteries. So,
yeah, we can just pause here. I think before we go talk about transplant, I think previous slide showed some non-immunologic features, and I think this raises one of the questions that was brought up about Dupixent and severe atopic dermatitis or use in hyper-IgE syndrome. I've had one patient who had severe atopic dermatitis who received Dupixent, who had clinical improvement. And there have been several reports of dupilumab being used in hyper-IgE syndrome with varying success. Also, I think omalizumab has been reported in hyper-IgE syndrome. I'm just curious to know if other people have had experience with transplantation for hyper-IgE patients, and if so, how did those patients do? Did they have any reversal of their other non-hematopoietic features? Was it successful, not successful? I do see a comment in the chat regarding Dupixent. I really started my patient on Dupixent based on the reports. He is doing well on it. Well, that's great to hear. We had a patient who was transplanted, the only one I've had, who had successful reversal. We measured Th17 phosphorylated STAT3 as pre and post transplant. That patient had several features that did not correct. She had severe scoliosis. She had pulmonary complications, including pneumatoceles and a nighttime oxygen requirement. But she was able to come off of antimicrobial prophylaxis. She originally got transplanted because she had breakthrough infections with antimicrobial prophylaxis, and she developed autoimmune disease, including autoimmune hemolytic anemia that was resistant to treatment with immunomodulators, including prednisone. I do see that there's we transplant in the chat, we transplanted a 6-year-old hyper Ig patient with DOCK8 deficiency doing well. Yeah, so this is not very common, I'm suspecting, is transplantation in hyper IgE syndrome. But I do think Armen's point is that, it is increasing in terms of number of institutions that are transplanting.
Yeah. So moving forward about hyper IgE syndromes, they share common specific features. They have common and specific features, and the common features pretty much for all of them is excessive elevation of IgE, eczema, recurrent bacterial infection, and mucocutaneous candidiasis. However, based on the gene involved, they have their specific features. And for example, in STAT3, impaired IL-6 signaling not only affects Th17 pathway, but also can affect the acute phase reaction, which leads to no fevers or cold abscesses. In our case, we saw that we had not that significant elevation of CRP with an appendicitis and septic presentation. IL-11 pathway is thought to be responsible for many non-immunological manifestations related to connective tissue abnormalities, whereas impaired B-cell maturation in the germinal center, along with the impaired mast cell and basophil degranulation, can explain why this patient, despite having these higher levels of IgE, do not have that often food allergies or environmental allergies. Whereas in other conditions, other genes responsible for hyper IgE, such as DOCK8 or WASP deficiencies, they have their own specific features, such as autoimmunity or food allergy and asthma, which are more commonly seen due to regulatory T cell dysfunction and malignancies, recurrent cutaneous candidal and viral infections related to impaired cellular T cell and NK cell deficiency. Going back to our patient and summarizing our case, to our knowledge, this is the youngest de novo STAT3 hyper IgE syndrome case with a genetic diagnosis. We diagnosed even before the IgE elevation. Interestingly, his immune manifestation coincided with elevation of total IgE levels, and in elevation of total IgE coincided with the lack of vaccine response. And I don't know if there are any studies looked that way to see if the IgE elevation can be a sign of specific antibody deficiencies. This is also the first case with histoplasma-associated appendicitis, who is currently on antifungal prophylaxis. He started to have non-immunological abnormalities, skeletal complications, which also presented very early in the course of disease. I know that GI plans to do endoscopy if his bowel dysmotility continues. Still, we don't know what was the reason of his very early manifestation of his immunological or non-immunological symptoms, whether this was his nutritional deficiency, his early vomiting and diarrhea that was a stress factor for his presentation, or the additional genes, although IL-17 receptor was listed as variant of uncertain significance and it was likely benign. I don't know whether it adds an additional drop in the CF STAT3 dysfunction in this patient. We just speculate. We don't know what was the reason of this early presentation. And with that being said, I would like to thank the audience for the attention, and I would like to express my gratitude to my colleagues, Dr. Horner, a wonderful attending teacher who diagnosed this patient this early and is following him up, Dr. Schmidt, who also took care of this patient while he was admitted with histoplasma-associated appendicitis, my co-fellow, Ran Hazan, and pretty much all our fellows took care of this patient. I would like to thank Dr. Freeman, who was always ready to help with advice and recommendations, and the doctor who gave us the pathology pictures. I would like to thank Dr. Patel for his readiness to mentor me today, and thank the audience, and we are happy to take questions. Thank you.
Great presentation, Armin.
Fantastic, fantastic. Any other final comments, Dr. Patel, that you'd like to leave us with?
I think I think Armin pointed out very well, this is a very early onset presentation and early diagnosis. So I think, getting genetics early on board is very key. And I think that can change the management of patients who are diagnosed very early. I think we always have to be on the lookout. I think this case taught me about fungus and the importance of disseminated fungal disease and hyper IgE syndrome and the importance of prophylaxis. And I think that more and more you will likely see as a treatment option for these patients, bone marrow transplant. But I think that's going to be very individualized and obviously conversation with the family and the bone marrow transplant service. So yeah, great case and just a lot of cool facts and interesting things about this case.
Yeah, there was one final comment, and I think you guys highlighted it, that, that just illustrates how an early diagnosis or confirmation of diagnosis can change the management and monitoring going forward. I think there's one final question, if you have a minute for that. There's just one person curious about the elevated IgE following / coinciding with the vaccination. Is it kind of a misdirected class switching to IgE instead of IgG, which is impaired? However, in CVID, IgE is invariably low. Any thoughts on that? Last comment.
Great question. I don't know the reason why. What was the reason of his elevated IgE in that age? Many people got their vaccinations in infancy and between the first and second year of life. However, even with this presentation was very early. Others are presenting the second decade of life typically. So if it was so, I don't know whether this is a typical pattern for these patients.
Yeah, I think it's hard to say. It could have been coincidence also. It's hard to say. I don't have a great answer for that one.
Perfect.
Yeah.
All right. Well, I think we'll wrap it up for this evening. Thank you, Armin and Dr. Patel, for your participation and presentation of this interesting case. I think there's a lot to learn here for audience members and a lot to think about going forward. Thank you all for joining us for this presentation this evening, and we'll see you back next month for our March CIS webinar. Thank you.
Thank you.